Thank you very much for the introduction. Sizable proportion of our patients became old age, either advanced maternal age, which is above 37, or age-related infertility, which is another issue. My presentation is that I will try to show that the current copy of IVF for ICSI that you are using is inefficient in old age women. So we all know that the number of oocytes decline with age to reach a very low number at 45 to 50 years when it comes to menopause. And fecundability decreases proportionate to the decrease in the number of oocytes. This is one. Anti-Mullerian hormone decreases and the oocyte number decrease also by age. This is decline of fertility, age-related decline, which is not a disease. So this is the first distinction. Age-related decline of fertility is not a disease, this is biology. With the decline in ovarian reserve, the data showed that the fertility rates, which is the number of births per 1,000, decrease also. And at age 40 or above, the fertility rate reaches 12%. Fertility rate is not pregnancy rate, it's the births per 1,000, and it gives an idea about the decline of fertility. I'm stressing again, age-related decline of fertility is not a pathology, it's a biology. When you look at the pregnancy rate per cycle, the chances of pregnancy per cycle, naturally, it decreases with age. But if you look at the chances of pregnancy, natural pregnancy per a year, you will find that at age of 40, there is a sizable proportion of patients that can get pregnant on their own still. So decline of fertility is a biology and infertility is a disease. So proportion of those who have decline of fertility have the disease or have infertility, not all of them. So as you can see in the last one, the chances of infertility increases with age. Why we are picking this? Because before I go to this, again, I want to stress that at age of 40, from all the censuses in the world, you will have around 30 to 40% pregnancy rate within a year without assistance. So this is natural pregnancy. So the story, decline of fertility is a biology because of decline of ovarian reserve. It is not a disease. Proportion of those will have the disease, which is infertility, which is age-related infertility. It is because of their oocytes. So why not give them a chance? Now we go to IVF. The chances of pregnancy in IVF per cycle at age of above 40 is around 15% and decreases to 5% or less per cycle when the age goes to 43 to 44. The chances of pregnancy per 3 completed cycles, 3 aspirations, with their frozen and their fresh, is very low when the age goes above 40. If you compare this with what we put for the natural pregnancy, you will understand what I'm saying. We are using an inefficient copy of IVF in this old age, because if you increase the cycles 5 times transfer, you still have the low pregnancy rate, as you can see in this data. It is partly because of mitochondria, and because of mitochondria, the spindle assembly is disordered, and because the spindle assembly is disordered, we have a high rate of aneuploidy. So this is what we mean by age-related decline, age-related infertility. That those patients have 80% or more chance of having aneuploid blasts at this age. So their problem is their oocytes. Their problem is their aneuploidy. Very high percentage of aneuploidy, which is also transmitted to the fetus, so that you will have 1 in 18 with abnormal karyotyping at the age above 44. So we explained that there is a biological decline of fertility, which is not a disease. It is characterized by decreasing AMH. It is characterized by rising FSH. It is characterized by lower antral count, but it is not a disease. They can get pregnant, and at the age of 40 or above, 30 to 40% of them will get pregnant on their own if they try enough for a year or so. So again, we are using an inefficient copy of IVF in this age-related infertility. So what should we do? Should we use conventional ICSI, PGTA, social freezing, embryo accumulation, adds-on, whatever? But it cannot go like this. I've been discussing with Fauzi yesterday and in a group that we were discussing recurrent implantation failure. This excellent paper from, it was published in the New Journal of, New England Journal of Medicine, which is a very high-ranking journal, and it is a very well-done randomized controlled trial, and they transferred 3 blasts tested by PGTA and non-tested by PGTA. The transfer of 3 blasts, tested and non-tested, no difference. Actually, the non-tested was slightly higher, but this is not a significant difference. So if you do 3 transfers, separate transfers for patients, you will not increase the chance of pregnancy by PGTA. And in younger patients, the data showed, I think the SARC data showed, that pregnancy with conventional ICSI as compared to with PGTA, same outcome as you can see from these columns. The only thing that made a difference in older age was the social freezing. And by social freezing, we mean freezing at a younger age than transferring later on, not freezing at 38 and 40. Social freezing means freezing at 30 or 31 or 29, whatever, because she intentionally wants to delay pregnancy. This is the data that is coming from this. Social freezing was the only thing that increased pregnancy in old age, but this is not old age anymore because the oocytes are younger. 10 years ago, they were frozen. If the problem was the spindle, and if the problem was the mitochondria, there is biological possibility to think that Q10 could act. And if we ask if there is an evidence, there is a meta-analysis that says Q10 would act. Okay, meta-analysis has weak studies, fine. They are weak studies, but we are in a desperate situation. A desperate situation requires desperate measures which are inexpensive and non-invasive. So adds-on, properly selected adds-on, who has evidence is a good idea to try. And there are some well-known scientists like Gleicher and others, they state exactly, we have to treat the ovary before we do ICSI for old women. So this is one thing, and Q10 acts for pregnancy, not for live birth. And similar data are present for vitamin D also. So to conclude, Chairman and dear colleagues, with age, ovarian reserve decline, this decline is represented by decreased antral follicle count. It is represented by decreasing AMH. Decreasing AMH does not predict pregnancy. Decreasing AMH does not predict menopause. So this is not a disease. Part of those will have age-related infertility, which is infertility related to their poor quality oocytes. So we have to do something. This is not, what we are doing is not working. Thank you very much.